Again, welcome. This is the PSPS APP webinar. My name is Jackie Weisbein. I am an interventional pain physician in Napa, California, and also on the membership committee for PSPS. And it is my great pleasure to introduce Zora Husseini, who is from the University of Kansas Health System in Kansas City. Hi, Zora. And Jill Studdy, who is at Nevada Advanced Pain Specialist with my friend and colleague Dennis Patterson in Reno, Nevada. Hi, Jill, welcome.
Hi.
And today the goal is talking about neuromodulation and minimally invasive surgeries and identifying patients and figuring out who deserves to do what and get what. And deserve is the wrong word, but how do you align the right patient with the right therapy? And a lot of that's going to be based on obviously diagnosis and also a number of other things that we plan on talking about tonight. So with that, I'm going to hand this over to Jill, who's going to take it off, and she's going to talk to us about who are our most noticeable neuromodulation candidates. So thank you so much, Jill. I'll let you take it away.
Okay, thank you so much. Happy to be here. So excited for PSPS. I've never been to Hawaii, so I'm counting down. So my name is Jill Studdy. I am at Nevada Advanced Pain Specialist, and tonight I am going to be talking about indications for neuromodulation. There are certainly a lot of options out there, so I'm going to really kind of go over the basic indications and approvals that we currently have. Some are old, some are new for these particular devices. So I'm going to go through spinal cord stimulation, dorsal root ganglion stimulation, peripheral nerve stimulation, and then also a bit on pain pumps as well. So as you can see, we're going to be starting with spinal cord stimulation. So the common indications that we're pretty used to here at this point, I just want to kind of go over them, are failed back surgery syndrome. So these are, a lot of the patients that we commonly see that, have had one, sometimes, I know I've seen patients that have had multiple spine surgeries and unfortunately are still suffering from a lot of pain. So those are kind of the main indication that's been out there. And then complex regional pain syndrome, type 1 and type 2. I am actually in PSPS. I hope all of you come to the APP segment. I will be talking a lot more about CRPS, but SCS is certainly indicated for both type 1 and type 2 CRPS. And then you have, your other nerve conditions, the arachnoiditis, the radiculopathies, your phantom limb and stump pain patients. And then the last two indications are kind of the newer indications, diabetic peripheral neuropathy. So what, I've personally noticed as this code has come out, or this approval has come out, is that a lot of these patients already exist in our clinics. So these are a lot of your patients that you might be treating for some other pain complaint, who they might, during your visit, they might briefly mention, the numbness and tingling that they've been having in their feet for many years. Or they might, you might notice that they used to ambulate on their own and now they're using some type of cane or assistive device because their balance or their gait is a little bit off. And other, they might mention that they saw their podiatrist or their endocrinologist. So just make sure you aren't missing these patients in your clinic and are definitely making sure you're working them up, because a lot of them have just been on, some type of gabapentinoid for a long time and would really probably benefit from a discussion regarding a trial of a spinal cord stimulator. And then the other indication that we now have is the non-surgical low back pain. So it used to just be completely denied if they, didn't have one of these other options, but now we actually are getting approvals for that chronic low back pain that you're seeing, and we see very, very commonly in our clinics as well. So definitely keep that in mind that we do now have that indication, and maybe those patients that, those ablations aren't working for them anymore, or the ones that, have been getting ablations and epidurals and all the other maybe minimally invasive procedures that just aren't working quite like they used to. Those are really good patient population that you want to consider for the spinal, when you're working up for your spinal cord stimulator. So definitely when you're considering intractable trunk and limb pain are great candidates for spinal cord stimulation. All right, and next we're going to be talking about dorsal root ganglion stimulation. So for these patients, you're going to want to be looking at more focal pain. So a lot more localized. You're not really going to want to be looking at those patients that have that radiculopathy down, both their extremities. You're really the main one that I feel like is just a huge improvement for patients that have that lower abdominal or visceral pain, and then the groin, pelvic, testicular pain patients that may have been through a lot of peripheral nerve blocks, TAPs, pudendal nerve blocks, sacral nerve blocks, ablations, and they either can't get the ablations because we can't get the approval through their insurance, or they get the ablations and they're just not hitting the mark like we want them to. I feel like I've had a lot of success with testicular pelvic pain patients in doing dorsal root ganglion trials. And then it is also indicated similar to spinal cord stimulation for phantom limb and stump pain, and then also your CRPS type 1 and type 2 patients. Those are also good candidates. So typically kind of how, anecdotally when I'm looking at those patients, if you have a CRPS patient that maybe, has a history of right knee or ankle trauma, and it's eccentric to that particular location, that is really going to be a good DRG candidate. And then even if they do have sometimes with CRPS, it will move over to the other extremity as well, or another one. If for some reason it's on their right ankle and then moves over to their left, you can do leads bilaterally for those patients with DRG stimulation as well. All right, so next we're going to be talking about peripheral nerve stimulation. So when you're working these patients up, really you're going to be looking at those patients that have that localized chronic intractable pain that's from a peripheral nerve. Typically with this, you're going to want to do at least one peripheral nerve block and see, how much temporary relief they get with that nerve block. So good indications are maybe your patient that had a total right knee replacement, and they're still, for whatever reason, if the hardware looks okay, the surgeon said there's, not much else they can do, that is a really good patient to consider doing a genicular nerve block. If that's successful, you can either consider moving on to the ablation, or if for some reason the ablation doesn't get them relief, that's when you really want to think about a peripheral nerve stimulator trial. On the other spectrum, you do also want to consider your patients that maybe have a lot of right, just kind of using the knee as an example for a joint. But they have a lot of right knee pain, but they're not a candidate for a joint replacement. So maybe due to X, Y, or Z comorbidity, surgeons are saying that they just aren't gonna do the right knee replacement. That is also a patient you really want to consider helping, because they really don't have that many options. And going down that same pathway, start with a nerve block, see how much temporary relief they get, and then if that's successful, then same thing, you can consider the ablation or just go straight to trialing the peripheral nerve stimulator. All right, and then next we're going to kind of switch gears and talk about pain pumps. So also an implantable device. This is an intrathecal drug delivery system that essentially sends medication directly into that cerebrospinal fluid, which avoids crossing over that blood-brain barrier. So you don't have those systemic effects of the medication. So good indications or candidates when you're working your patients up, you want to think of those chronic non-malignant pain patients. So some good, examples for a pain pump might also be what we talked about with the spinal cord stimulators. So the failed back surgery syndrome, you can definitely consider doing a pain pump trial as well on those candidates, or your, maybe your pancreatitis patients that have that kind of chronic abdominal pain that's more localized, and then you can, go in and put the intrathecal system in there and see how much that helps with that chronic pain syndrome. Another good consideration for the non-malignant patients are maybe when you're working up your elderly patients that maybe aren't able to get into their office visits like they should. Maybe they can only come in, they get that 4-week mark is just not applicable for them, and they, need to, need something that's going to give them longer term options for coming into clinic, maybe like every 3 months. Depending on the dose, it can be as long as every 6 months when you see these patients. Or your patient, the elderly that just aren't good with their pills. You certainly want to treat them and you want to help them, but somehow their dog's medication or their significant other's medication pops up in their UDSs, and they're just not good oral pill opioid candidates. Those would be some other patients that you would want to consider doing a pain pump trial with. And then your muscle spasticity patients, certainly with the baclofen is typically a pretty big game changer for those patients. And then your cancer related patients, one thing that I did kind of just want to wrote on there to note is that sometimes if they're farther along, depending on what stage of cancer they have, you and your collaborating physician can maybe have a discussion of considering skipping that trial period and just going straight to implants, depending on how that conversation goes with you and the patient, and even the oncologist. All right, so just some basic considerations I just wanted to go over real quick. Questions that I typically get, how soon is too soon to initiate the discussion? I always like to kind of put all my cards on the table sooner rather than later. I don't, I know how you ladies feel, but I feel like most of the time when I'm introducing advanced procedures, usually it's a good another couple months for patients to actually feel like they have enough information and education and family support to actually follow through with the treatment plan that I'm suggesting. So I personally bring it up sooner rather than later in those office visits. Keep in mind that this is one of the few things in medicine, as far as with any of the neuromodulators and the pain pump, that you can do a trial prior to implant. I just think that's absolutely huge for patients. There's no surgery that a doc can say, we'll try this out real quick, and then if it doesn't work, I'll take it back out. This is kind of one of the few things that a patient can have, that trial period where, I always kind of tell everybody it's my job to educate and inform you on, why you're a good candidate for this procedure. And then at the end of the trial period, I want the patient to tell me, why I should be implanting them. So I kind of switch that around because I do really want them to be, in the driver's seat, especially when we're putting any type of implantable device in them. You really want to make sure that they're very well educated and comfortable with proceeding. And then, just some other things to think about with the neuromodulation is that you do have the option of rechargeable versus non-rechargeable. So maybe you definitely want to be considering that for your patients that, again, kind of the elderly that might, don't even have a cell phone, don't even want to touch a cell phone, they don't want to touch anything with technology. Then you're definitely not going to want to have, put in a device that they have to try and charge every single day. And even you might have, your active young patient, your 30 something 40 something year old parents that are running around with their kids, and they just don't have time to be being there to charge that device. Those are also conversations that you want to have with that patient. And hand in hand with that is, with all the different companies out there, there are several different waveforms, and with that comes different energy use. So you do want to keep that in mind when you're picking what device you want to proceed with for the patient, when you're having that conversation about how often they really want to be in control versus maybe just sitting back and having it implanted and never touching it again. Because their energy and waveform usage might be a lot higher than some, certain patients, depending on their needs. And then just the last thing to consider, there is the option of the internal versus the external IPG when it comes to the spinal cord stimulators, DRG. All of that is internal and implanted for the implant. But then for the peripheral nerve stimulators, there are a couple companies that have, the 90-day and then it's explanted. And then another company that just has the battery that's actually external, and then the IPGs, very small, about kind of the size of the tip of your pinky finger, and that's the only thing that's implanted under the skin. And then the patient charges everything else externally, so they don't have, I know I've had some patients that just don't want an internal battery implanted in them. So those are just kind of some other considerations when you're working patients up. All right, and then obviously goals of neuromodulation, reducing pain levels, certainly reducing MMEs as best as you and that patient can once you get that implantable device. That's kind of another conversation I have when I initiate that discussion is, once you're implanted, we're gonna maybe try and reduce those MMEs. And then, improving the quality of their life. Most of the time I just hear from a lot of my patients that they just wanna be able to stand at the kitchen and cook and clean and do the things that they once were able to do, and with that increasing activities of daily living, physical activity, and then another goal for neuromodulation is also improving sleep, which is a big one that we hear all the time is impacted from chronic pain.
Thank you so much, Jill. That was a really good synopsis, and definitely a couple other things that I'll talk about when we talk about some pearls to remember towards after this. But with that, I'm going to pass it on over to Zora, who's going to talk about minimally invasive spine candidates. So thank you so much, and here we go.
Awesome. Thank you so much for the introduction. And Jill, I think that was a good intro for neuromodulation and ITP pumps as to managing usually the symptoms of pain. But in my particular topic here with minimally invasive spine surgical options, we're looking more at actually treating the condition and trying to fix the problem. So the first subject that I'll kind of bring up is lumbar spinal stenosis. This is probably one of the most common reasons that people undergo surgery who are older than 65. So it's that common deteriorative wear and tear process that occurs in our spine over the course of time. Occasionally we'll have like injury-induced issues as well that might contribute, but a lot of the time we're just seeing deteriorative changes in a patient's spine that causes compression on the nerve, and then they, have difficulty with certain symptoms that come with that. So essentially, there's primary, conservative options that we give to the patient, like PT and, medications, and we'll trial different epidural injections or different types of interventions traditionally that we've had to help these patients with their pain. But sometimes that doesn't necessarily last or doesn't work as well as they had hoped, or that function continues to be somewhat limited by pain. And as we mentioned, devices like neuromodulation and such with pumps and stims, you're helping the patient manage the symptoms, but it's not correcting the problem. So when we look at spinal stenosis specifically, it is a problem that's affecting the actual spinal canal, nerve root canal, and or the neuroforamen. So anatomically, there's kind of 3 segments of the spinal cord and areas around the cord that can be pinched. And typically these symptoms are going to be patients that have back, buttock, and or leg pain. And sometimes they may not have back pain and just have leg pain. They're usually going to have radiating symptoms down their leg, numbness, tingling. Occasionally, that'll also induce weakness in their extremities. So definitely a point that you want to make sure you ask patients is, do you have any difficulty with strength in your legs? Do you have heaviness in your legs? Do your legs drag? These are sometimes not a particular symptom that a patient will associate with their back or leg pain. So you want to make sure you ask that question because that is pertinent to the workup as you're potentially diagnosing stenosis or any kind of nerve compression, related problem. Again, these are usually worse when the patients are standing. It's very mechanical in nature. So when they sit or rest, the pain's usually alleviated. You'll find these patients leaning forward when they're kind of walking, possibly hunched over their cane or walker and or furniture that they're holding on to. And then the classic sign of the shopping cart sign, where you see patients really leaning heavily or relying on the shopping cart to alleviate the pain, which then they can get through their grocery shopping a little bit more adequately as long as they have the cart to hold on to. So when we look at these surgical options, this would probably be the most common one we see patients undergoing surgery for. So we can, look at this as when we discuss these other minimally invasive or Band-Aid surgeries for spine, we're looking at decompression of the nerve. The first treatment is going to be the percutaneous image-guided lumbar decompression, also known as that minimally invasive lumbar decompression treatment. And so what this is really focusing on is decompressing or debulking these posterior elements of the spine, which are essentially the ligament and sometimes that lamina as well. So when you're looking for a patient that would meet the criteria, imaging is going to be very important outside of the symptoms that we discussed on the previous slide. So generally, the content of what is entailed in this, there's no implant. It's fairly minimally risk procedure where the patients are going to have possibly, a similar potential risk as an ESI injection. So there's a tool essentially that goes in and they debulk or take out some of that posterior ligament and help basically create space. So the indications for this treatment usually going to be patients who've had mild to moderate lumbar spinal stenosis, most often where that's going to cause central stenosis, but there are patients that in the studies also had lateral stenosis and narrowing foraminally, as well as degenerative changes that contributed to the canal narrowing. But central stenosis is really the common one we see, and these patients generally have that neurogenic claudication where they find the pain gets better when they sit or rest. Uniquely, this particular decompression treatment, as opposed to some of the others that are available, does assist in the area of the L5 to S1, including that zone. Whereas in other decompression treatments we'll talk about later, it's not an option for the L5 S1 region. So anywhere in the lumbar spine down to S1 are the levels that you can do this treatment in. And also if the patient has significant weight issues with a BMI over 40, if they have poor bone health, these are also going to be not as much of an issue for the patient to undergo this particular procedure. So we'll talk, that'll make more sense as we discuss that in the future slides with the other treatments, but essentially fairly safe procedure. They're debulking the ligament. And so when you're looking at imaging and you're assessing a patient's MRI, you really want to look for that hypertrophy of the ligament, specifically being the primary source of what's causing that compression. So per documentation and or clinical indication, it's got to be at least 50 to 80% of the source of compression. So if the majority of the problem is a disc issue that's compressing, you're not probably going to get as much of a response because we're not going in and debulking the disc. It's the ligament itself that we're treating with this particular procedure. So in the image, you can see highlighted in blue, that black highlighted blue area essentially is the ligament that's enlarged, which then compresses around the lateral, lateral nerves and causes that pinch around that central and lateral area of the spine. So as far as the imaging goes, these are kind of the common things you want to look for as an MRI to assess the compression and making sure that that's the ligament with a greater than 2.5 millimeter thickening, essentially. And then bending films with an X-ray is going to be important just to make sure that the patient doesn't have significant instability with a listhesis of greater than a grade 2. So if it's more than that and they're like a grade 3 or 4, likely this is not going to be the best option because that patient needs some stability. But if it's anything less than a 2, then the patient would still qualify. And again, if the patient has had any prior surgery at this level where that lamina and or a prior decompression has been completed at the level that you're treating, then that wouldn't apply. So you wouldn't be able to do that if there's any prior surgery with any decompression there before. So anything above and below that, so if a patient, let's say, had a fusion or some prior treatment, and then they have a level above or below that does have the normal spinous process and lamina intact, then they would be a candidate for that at a different level. The alternatives that we have in comparison that would be a decompression surgery are interspinous spacers as well as interspinous fusion devices. So these are going to be indirect decompression treatments. Specifically, I'll kind of focus on the spacer. These do uniquely differ just a little bit. So the spacers really are going to address that stenosis by decompressing the spine through limiting spinal extension. So when the patients generally come in with that forward flexed posture, it's because that's what's opening up the space in their spine to help alleviate the pain. This particular spacer device can be implanted at either 1 or 2 levels, and they have to be adjacent levels if it's 2 levels. So in the image to the left, the top one is the spacer device. These patients, again, as I mentioned, can only have the device placed at the L1 to L5. So it does not include the L5 to S1 because you have to basically have a spinous process to support the device. And so at the S1 level, obviously there's not a prominent spinal process and therefore the device would not apply to that lower level. Generally, if the patient has any kind of instability, especially with the spacer, it's going to be a little bit more limiting. So if it's less than a grade 1, then they would apply, and they have to have less than 3 millimeters of translation with flexion and extension. So again, having those imaging studies available and ensuring that there's not any specific movement beyond that, then the patient would still qualify. Both of these particular treatments usually apply to patients who've had anywhere from about 25 to 50% of the spinal compression by evidence of either thecal sac compression, the nerve root impingement, or the hypertrophy of the facets that then cause that canal to be narrowed down. Alternatively, the fusion device, so when we look at the bottom image, that bottom device in the image there, this particular device is still a device that we're implanting, if you want to call it like that spacer. But this particular device actually does fuse or stabilize. So it's uniquely different in the sense that we're providing more than just decompression by putting a device in. You're actually creating a fusion to stabilize the adjacent spinous process. And so this particular one is a little bit maybe superior in the sense that if the patient has had multiple deteriorative changes and they do have that instability, they probably would actually benefit from this fusion component to help stabilize that spinous process. One of the big things that a lot of patients cannot undergo major surgery for is the risk of surgery, like major open surgery, spine surgery. And so when we look at what can we do to help fix the problem that's not going to put them at that high risk, these would be those options. There's still surgery, so you have to make sure you understand and tell the patient that this is still a surgical procedure, but it's much less invasive, and we're really kind of providing that relief and or fix without going through the big risky procedure. So a lot of patients may not qualify for major surgery because of, comorbid conditions, problems with, tolerating anesthesia. If they're overweight, some of these conditions can be factors. And when we look at this particular device implant, we do have to still consider some of those, especially in patients who have scoliosis and that curvature is greater, that Cobb angle is greater than 10. That's going to limit how successful these devices can be in that area. Again, if you think of the anatomy and there's a big curve, that spacer may not stay put, right? So it depends on the spinous process above and below to kind of be somewhat aligned. So anything more than a 10, you're not going to necessarily consider this option for the patient, specifically if that curve is at the index level of treatment. So if they have an upper cervical problem and their pain's all lumbar, as far as the curve being up higher, it's not going to affect the lower spine. So it's only if the curve is at the index level. If they've, again, had prior surgeries with fusion or hardware, or their spinous process is missing, they've had a LAMI or something like that, again, you're not going to be able to optimize this particular device if the surgery is done at the index level. Patients who have high BMI greater than 40, again, you're going to want to be cautious as to whether this is going to be the best option for the patient. Bony health, as far as osteoporosis and making sure you check those bone mineral density scans, are going to be important because it depends on the bone health. You don't want to fracture or something that will destroy the bone structure by trying to put these devices in. And then if the patient has like multi-level spinous stenosis, then you really want to be mindful that this may only be able to treat 1 to 2 levels. So you're not going to be able to fix all of it by putting multiple implants in. So you just want to be, again, selective to patients who may have 1 or 2 levels only, and then trying to help to manage that problem through this device. Beyond decompression, then we look at alternative sources. So lumbar spinal stenosis, like I mentioned, is going to really focus in on how we decompress the nerves. But sometimes patients may not have that radicular pain or the specific symptoms of stenosis and may just have axial back pain. So a lot of times as we look at identifying the source of the pain, you really have to, again, look at imaging, think about what the patient's telling you, what are their symptoms. And patients who have facet-mediated pain usually have axial back pain. And if facet fusion is the alternative treatment for minimally invasive surgery that can help stabilize those facet joints, and it basically fuses the joints to help provide that stability. And these are small tools that are inserted by a device basically that then fuses the joint. And typically these patients are those who have persistent localized axial back pain, no leg pain. Typically it's worsened with movements of extension and flexion, bending and twisting. Facet loading is typically positive in these patients. So what are we looking for on imaging? For the most part, you're wanting to make sure, number one, that there's not any significant pathology of stenosis or other sources of deteriorative changes that are maybe the source, right? But again, when we're looking at asking the patient their symptoms, if it's mostly axial pain and they have significant facet hypertrophy on an x-ray, then that's going to clue you into that being a potential source. The other thing with the MRI is sometimes you'll see fluid in the facet joint, which also tells you that there's instability in the joint. That's not always present for patients that could qualify for this, but that is a big sign that we would also look for. And that, again, like I said, indicates some instability. Patients who have undergone like a lot of RFA treatments and they traditionally help, but maybe aren't lasting, or maybe the patient's starting to have pain that's just not getting benefited any longer by an RFA, those would also be good candidates to consider for facet fusion as long as they fit that criteria as mentioned. Contraindications really would be, once again, patients who have greater than, like a grade 1 or 2 instability. As far as like listhesis goes, other deformities of the spine that affect the joints that obviously if we're putting a device in to fuse them and that joint is missing or there's been surgery there, then that's going to not let the patient be a great candidate. So again, just being mindful of some of those other factors too. We're looking at the sacroiliac joint as a potential source of back pain. Typically, this area and joint is usually about 30% of the time the source of the pain. And so when we're looking at patients who've had chronic lower back pain and you take an MRI of the spine and they have significant compression, we really want to assess that the patient has been adequately diagnosed as to what that source is coming from. So generally, this pain can be very similar to lumbar, radicular, or lower back induced pain by some type of spinal source. So you really have to ask the right questions. And there are specific, what do you call it, physical exam factors that you would look, provocative tests essentially. And so these particular tests, as listed in the box on the right, are going to be key to assessing the patient and getting authorization for these particular treatments. But typically the patients have kind of that localized pain over the SI joint. It can travel or radiate to the groin, sometimes to the lateral thigh. Again, it may mimic some of that radicular symptoms that patients may feel. But more so, I think the key symptoms that when I talk to a patient are, it hurts when I sit for long periods. It hurts when I try to get up and stand from a sitting position. Typically any rotational, especially external rotational hip movements can also aggravate the pain. And so these patients usually can benefit from an SI joint injection if that's been beneficial for the patient and they continue to have persisting pain or those injections just don't last. Again, we can consider the SI joint fusion. And so that particular fusion treatment basically fixes the problem. So then they don't have to come back in and do injections long term. So we kind of talked a little bit about multiple types of spinal devices. It's a little bit hard to remember everything. So I made just a quick flow chart with regards to some of the key things that we see in patients who either have back pain and generally no leg pain. Is it an SI joint dysfunction problem? Is it a facetogenic problem? When we're looking at imaging, what are we trying to rule out or rule in? Typically with SI joint, on physical exam, they have to have provocative maneuvers that are positive. And again, looking at diagnostic injections and joint injections being significantly successful, then the patient may benefit from a with a SI joint fusion. I apologize, that should say SI joint fusion on the first green box. In the second phase of patients, again, just lower back pain. They have facet hypertrophy. They've done well with RFAs in the past, but just not getting relief. Then the facet fusion would be the adequate consideration to offer for the patient. When we're looking at back and buttock or leg pain, whether that's with or without back pain, typically these patients, especially if they have lumbar spinal stenosis, we talked about the percutaneous lumbar decompression through ligament debulking, and then the spacing devices. So hopefully this gives you a quick overview and can help kind of give you a guideline as you're looking for patients. I think we have some case studies, so I'll let Dr. Weisbein get back to it.
Zora, that was so great. What a really beautiful synopsis that you and Jill both put together. So I'll let you and Jill come on, or Jill, if you want to stay off, whatever you want to do, because in a second, well, great. We're going to talk briefly about some clinical pearls. I think you guys did an amazing job describing so many important things that we think about in our practices. One of the things I always think about too, that's really challenging often for patients is, what is the diagnosis that they're treating? And I think a lot of issues are that patients don't always have a great understanding of their health, right? So they come to you and they say, I have back pain. And you say, okay, tell me about your back pain. And they say, well, I have an L4-5 herniated disc, right? And so they assume that the imaging automatically indicates this is my diagnosis. But what we know is that, the imaging is just a tool, and that used in conjunction with the history and the physical, both what you guys described very eloquently, is something that helps us kind of determine, what are we really treating, right? And then to the points that you guys had, absolutely, has the patient already had surgery? Because that's going to help us determine, what they are and aren't a candidate for. So if they've already had a decompression at a level or hemilaminectomy, you might not be able to use some of the interspinous spacers. You might not be able to land your piled trocar on a lamina if there's no lamina there. So kind of really understanding what you're treating with these patients, and then what makes the symptoms better or worse, right? So a lot of patients who have stenosis also have facet pain, right? And so if you ask them specifically, just do you have pain when you're up and standing? You're going, oh, well, is it stenosis? Is it the facet? But I tend to think, exactly what you were describing, Zora, is that with these patients with stenosis, then they sit down, they get better. Whereas with facet, a lot of times the patients, I ask them, like, are you stiff first thing in the morning, right? So when they wake up in the morning and they're stiff, then I'm thinking more, okay, maybe it's more your facet stuff, or maybe it's your SI joint, right? So it helps us kind of put a clinical picture. I think too, one of the hardest things for patients is, when you talk about SI joint pain, not every patient is going to have imaging that indicates there's some kind of SI joint issue, right? So oftentimes these patients have normal MRI findings of their SI joint. Maybe you're thinking of your patients with ankylosing spondylitis or other diagnoses that may give them some more arthritic changes in their SI joint. And it's interesting because they're not often read frequently by our radiology colleagues. What are the goals for these patients, right? I think goal setting is always super important. One of the things you both talked about is when do you introduce these topics? And I tend to introduce them really early on in the treatment of these patients. So I kind of want to tell them, hey, there's this whole like buffet of options, because sometimes their patients are going to come to your office and they may or may not have seen someone else. Maybe they've seen someone else who only does really bread and butter pain management stuff. So they're only getting access to like epidurals or medial branch blocks, but they don't have um, ever had experience seeing someone or a practice that offers some of these more advanced procedures. And so they might be more willing and ready to jump in with a more aggressive treatment, like neuromodulation or minimally invasive surgery, because they've already done the bread and butter stuff, whereas some are maybe coming to you directly from their primary care, things that they've tried and failed. And could you be missing something? I sometimes feel like one of the things, I always try and take a step back and look at my patients and think about, are we just doing the same thing over and over again? What's the definition of insanity, right? So you're doing RFA, things are doing well, maybe they're not working. Maybe really it is a stenosis, and maybe you're looking at that stenosis and you're like, oh, it's only like mild to moderate. But remember, patients can have mild to moderate findings on an image and still be having some significant symptoms. The last thing I'll really like to discuss too is ICD-10 codes for the region. So, I think one of the most important things to understand, specifically in our Medicare patients, particularly Jill, you talked a lot about some of the new indications for spinal cord stimulation. If you look at the Noridian guidelines, and as we're in PSPS, I'm going to assume a lot of us are using Noridian Medicare. But when we look at Noridian, that's going to cover Washington, Alaska, American Samoa, Arizona, California, Guam, Hawaii, Idaho, Nevada, Northern Mariana Islands, and Oregon. Those are of us who are in that region for Noridian. There is an entire ICD-10 list of codes that are specified for specific diagnosis, and you'd be very, very interested to find that for those of you who are trying to treat your patients with non-surgical low back pain or other things with different types of neuromodulation techniques, that there are a lot of ICD-10 codes that you may not have thought were going to be covered for spinal cord stimulation. So really getting up to date with those. And if you'd like to reach out to me or just Google Noridian ICD-10 codes for a specific CPT, you'd be amazed at what you can find out there. And it really may extend your reach for some of these patients. Jill, you spoke really beautifully about peripheral nerve stimulation. I tend to think about those patients too, specifically for my patients with upper extremity shoulder issues. So you talked a lot about knee, but we have DRG, and some patients may not want an implantable device for their lower extremity, but a lot of upper extremity patients, shoulder patients, things like that, peripheral nerve stim is a great option because DRG is really not indicated for that high. And though a lot of people are using it off label for higher levels now, for those who aren't, or in practices that don't have access to that, understanding what you can and can't do for those patients is great. So those are some brief clinical pearls. I want to just move forward now next, and we're going to talk a little bit about some cases. So this is a patient that was actually referred to me from a colleague who does bread and butter pain. She sent me this patient. She wasn't sure what to be done, but she actually referred this patient for a spinal cord stimulation. Patient had low back and lower extremity pain after a motor vehicle accident. Symptoms aggravated by lifting, standing for prolonged periods of time, walking long distances, constant sharp aching, stabbing, 6 out of 10 on a regular, 8 out of 10 on a bad day. She had some arterial issues in her leg and started having pain in her leg as well. So it was kind of unclear what was going on. She had had epidurals and facet treatments in the past. After I reviewed her notes, she did some physical therapy. She was using ice and heat and CBD gummies. And again, she was referred specifically for spinal cord stimulation. So I looked at her MRI. I examined her. If we can go next. So on her MRI, I didn't put the whole thing because it could have been really long, but there was significant foraminal stenosis. So on the MRI, there was some central stenosis, but it wasn't so bad. Most of the issues looked to be more foraminal stenosis. She also had some significant SI joint pain findings on her exam. She never had an SI joint injection. So I said to her, hey, why don't we try this first and see, maybe we're just missing something. We did an SI joint injection and she did really well. She had an 80% improvement for a few days, but then she started a new medication, had a number of side effects. Her pain flared, her blood sugar stayed high. Both she and I were not convinced her pain was SI joint mediated or completely SI joint mediated. So what do we do next? So again, this is a patient with some foraminal stenosis. She has pain with standing. So could have gone in a number of different ways, right? So could have considered, could have considered something like an interspinous spacer, could have potentially considered something like, the minimally invasive surgeries that are kind of, they're called fusions. I hesitate to call them fusion because really what we're doing is kind of stabilizing. They're more of an extension blocker, like you talked about, Zara. I think, some surgeons would say that true fusion indicates decortication of bone. So when we're kind of clamping something on a spinous process, is that true fusion? And I think that's a debatable topic that we're not going to get into tonight. But anyway, there are a number of different things. But again, this patient was referred to me for spinal cord stimulation. Out of respect for the referring physician, I said, these are our options. Would you like to try this? And we opted to try spinal cord stimulations. And patient had a spinal cord stimulator trial. This actually just happened last week. She had 90% improvement of her symptoms during the trial. Now, I feel fairly confident moving forward with spinal cord stim with this patient. And the reason why is when I do my trials, particularly for my Medicare patients, I do them in my office with no sedation, so only local. So I don't ever worry that the patient's having some kind of effect where, oh, maybe they got some like IV pain medicine if they're not taking pain medicine, and they're having some residual response to. So trial with just local had 90% relief after a week. And so, she's moving forward. But again, there were a number of other minimally invasive surgical options that we might have considered. I know Zora has a great case too, so I'm going to move forward in the interest of time.
Thanks. So this is a busy slide, but basically this was a patient that I'd seen like back in 2012 or 13 early on, and he was having issues with back pain, neck pain, originally for neck pain, and then over the course of the years, lower back started becoming a more primary issue. He did have some radiculopathy early on, went through a lot of epidural injections and kind of had the gamut of the routine things that we typically do for chronic pain, back then at least, that was available. So over the course of time, though, things started to change. His pain shifted, really more in the back than in the legs. He didn't really have any weakness, wasn't significantly having a lot of radiculopathy at the time, but it was really bearing down on his capacity to function, really affecting his quality of life. He was getting older. It just felt like, he was deteriorating in a sense because he wasn't as functional. No major surgical history in his lower back. He'd had a cervical fusion, had some knee work done. Again, traditionally epidurals had been done and they did actually help with his lower extremity pain at the time. RFAs were offered and he was getting those maybe once a year. He'd come in and get the RFA, was taking some pain medication over the course of the years, but did have trouble with addiction and dependence. And so that became an issue that was treated. Again, had spent several years with the folks that do like the Suboxone treatments and all that, went to kind of that med management group and was off of the meds and kind of just wrote it for a while. But he returned to come back and see us within the last couple of years. And again, the progression of his pain just became an issue where at this point he wasn't taking meds, wasn't interested in taking medications, but was just really desperate to try to find some better quality of life. So we did some updated imaging. He did have pretty bad spine, general kind of deteriorative changes, facet changes, ligament changes, disc deterioration. So kind of a gamut of things that were going on. And as you can see, based on his MRI, plus the CT scan that were done, had some listhesis, quite a bit of severe multi-level facet arthropathy as well. But symptomatically, right? So we talk about you can have an issue, but just because you have a problem on your imaging doesn't necessarily mean that's where you would automatically treat, because it all depends on what symptoms you're having. And so in his case, it was literally all back pain, worse in the mornings. You know, he felt like it was worse when he was active in certain ways. Those types of things really kind of clued us into what options we could offer this patient. And like Dr. Weisbein said, there's options where stimulation would have been a great option for this patient. He actually was, because of that significant benefit with RFAs in the past and his very axial, kind of achy, worse in the morning pain, we talked about facet fusion with this patient. And the diagnostic injections that he trialed were 80% relief for 6 hours. So he just had his fusion last month, and we did a follow-up appointment with him 10 days post-op. Patient was bracing, he was healing really well, and he already was having significant reduction of pain in his lower back. So would he have been a good candidate for a spinal cord stimulator? Absolutely. That could have also been something that he may have benefited from. But again, when you can kind of potentially consider a fix for the patient, that definitely would be something to look into as well, if that practice or your practice has the capacity to do those particular minimally invasive surgical treatments as well. So he was just one of those classic patients that I'd been seeing for years. And then, you know, when new things start to come about, you kind of start to clue into, you know, I've had this guy for years and years and years, and we've done epidurals forever. Is there something more that we can now do for them that actually can maybe correct the problem? So in his case, the facet fusion really was a successful treatment.
That's really great. Well, it looks like we haven't had any questions. I think that if it's okay for the next just kind of last couple of minutes, 2, 3 minutes, I will just pose a couple of questions for you guys if you're okay with it. So first, Zora, thank you. That was a great case, and I think really kind of emblematic of just what I was trying to say too, is exactly like you have to use kind of you know, what's available to you in your practice. So Jill, I have a question for you. When you are seeing your patients, you said you like to introduce some of these more advanced techniques earlier. So is it kind of like something that you let them sit and ruminate on for like a couple of visits, or is it, you know, by the like what would you say to someone who's new entering the pain space? Like, you know, I'm dealing with these patients, sometimes I'm presenting it and they're just very standoffish about it. So how do you get people to you know, feel okay about an advanced procedure when it's a new idea for them?
Yeah, that's a great question. And I think, you know, one example I would have was actually from a new patient that I saw today. She has had 3 very invasive surgeries on her right wrist, and still is having a ton of pain, kind of very localized to that particular area. You know, I spoke with Dr. Patterson. We were both kind of considering, you know, causalgia versus, you know, some other diagnoses on the table. So, you know, that was the first visit I ever had with a patient. That was the first time she'd ever even been in pain management. So she was kind of one of those newer cases. Like you mentioned, you might have somebody who's, you know, already done a bunch of procedures and, you know, just is really ready to jump right to those advanced procedures because they've already been through the SEs and the RFAs. But this particular patient, she'd just been through 3 invasive wrist surgeries. And really, I just brought it up at the first visit, you know, that we were gonna, you know, I was considering that on her, you know, diagnosis list, and kind of just briefly kind of talk to her about what CRPS and causalgia means, and then really, you know, talk to her about her options going forward. So I talked to her about starting with a, you know, minimally invasive, like a stellate ganglion block, and then, you know, I also introduced, you know, that if that does not work, or if it's not giving us as much relief, that, you know, we could consider doing a spinal cord stimulator for her. So I try and bring it up at first visit, and then, you know, but obviously you have a lot of follow-up patients, and then just make sure that you're really, when you're seeing these patients back, that you keep talking to them about like, hey, you know, this is how well this went, but, you know, follow up with me again in another couple weeks. Let me know how you're still doing at that point, and then we'll still discuss, you know, maybe give them educational packets, your your device reps are also really good resources. If you don't have a lot of time in clinic, you're seeing 30, 40 patients, but you think that that patient would be a good candidate, you could always, if you have good relationships with your reps, say, hey, I think you would, might benefit from this. I'm going to have them maybe give you a call in between our office visits so they can present more information, or I'm going to give you this packet so you can look into it more and then have some more time at that next visit.
Great. Thank you so much. That's a really great answer. We have a question from one of the people in the panel on so if patients have lumbar spinal stenosis or non-surgical low back pain, do you feel that spinal cord stimulation will ultimately fail over time? Is it better to treat the stenosis first and then consider the stimulation after? I'll be perfectly honest. The answer, in my opinion, is yes. So I talk about patients with, like, when I talk about stenosis, and that was a slide actually of like some Vertiflex that I did for a patient with stim that had a stim placed before her stenosis got symptomatic. I mean, I think about stenosis in a lot of these patients as something that is mechanically compromising the nerve's ability to transmit energy, right? It's being compressed. And so if it's not able to transmit that energy and power, which is why patients have that like heaviness sensation or the painful sensations that they have, then it's potential that spinal cord stimulation could absolutely fail over time. Now, realistically speaking, we don't treat images, right? So you can have patients with very mild stenosis who are very symptomatic and patients with very severe stenosis who are not symptomatic. So I guess the answer is, in my opinion, probably, maybe, yes, but everything is patient specific. Zora, real quick, two questions for you. One is, did the patient have a radio frequency prior to that facet fusion? I believe I heard you say yes, but I'm assuming that they had a radio frequency at some point. Is that correct or no?
Yeah, he did have it. It was probably within the year, but not within 6 months. It just previously about once a year he'd come in for them, and then they just weren't lasting as long. So the next step was, well, do we go back and do it again, and then it doesn't last a full 6 months, or do we talk about some other options at this point? And we actually had discussed SCS with him as well, but this was something I'd referred him over to our doc that does the SI or the facet fusion, and worked him up. They did the diagnostic, and he did so well. So obviously, if down the road he continues to do poorly, then something like an SCS may be another option for him. But yeah, he had trialed them, but it's just a while back.
Yeah, I think one of the things we always think about too is, pain is so multifactorial, and I think patients want to be cured, right? And so they go to have a surgery because they want to be cured or they want to be fixed. And the reality is that may not always be the case, right? They may have one treatment that treats one thing and one treatment that treats another. We have one last question regarding intrathecal pump patients. So this is something that I'm passionate about. In terms of chronic non-malignant pain, what results have you seen? In our practice, we've had much better results with treating cancer pain. So I was part of a study. There were two kind of landmark studies regarding low dose intrathecal opiates. One was Jay Grider and the other one was Magid Hamza, and I was on the Hamza study. And so both of these, we completely weaned our patients off prior to implant. So patients that were on oral opiates were weaned off their medication. Now, with Grider, they were weaned prior to trial. With Hamza, they were weaned to 50% prior to trial and then were implanted. I think that if I can tell you from having worked in a practice where I was after fellowship, where we came out and we just kind of took patients who were already on like pretty high dose opiates and just put a pump in them. If you have someone who's already got hyperalgesia and then you just deliver the medication in a different way, they're still going to be pretty hyperalgesic, right? That's not changing anything. But the goal of weaning those patients prior to implant and keeping them on those much lower doses is, I think, really amazing. And then also really utilizing flexible dosing for those patients, because we know that, the way the way the fluid in our system is moving, it's not just kind of like a stagnant thing, right? There are a lot of these kind of waves and motions. And so when we bolus those patients or dose them with flex dosing, just like we do in baclofen patients, we see a lot better results. So if you'd like, please reach out to us. I'm sure any one of us can get you a copy of some of those studies to read. And Medtronic's got some other ideas too that they published recently on this low dose opiate thing. So in the interest of time, I would say, Zora or Jill, do you have any other last minute things you'd like to say? I don't mean to put you on the
I
spot.
would just say, get to know what those therapies are, familiarize yourself, read the evidence. If you and or your provider doesn't offer it and you know someone that does, inquire, become, like colleagues and or build relationships so that you can get the patients where they need to go, where they're not just told this is the last thing we can do. So just making sure you know what those options are, and trying to just learn about them to educate your patient, advocate for them.
Great. And Jill, any last minute comments?
I'm muted again.
Yeah.
Yeah, I appreciate all this information. I always learn so much every time I'm on these. I think the biggest thing, kind of like you said, is just make sure to kind of take that extra second to take that step back when you're looking at these patients, and really make sure there's not something you're missing and that you're picking the right advanced procedure, because there are so many out there. But definitely, take that extra second and, talk through everything, and really pick the right procedure for the right patient and vice versa.
Yeah, I think that's a great comment. Not everybody's body reads the book, I tell my patients. And so even though they might be presenting in some way, just because they don't respond to one therapy doesn't mean that there's something else they won't respond to. So with that, next slide, Lakin, I'd like to say thank you to our lovely panelists. Thank you so much, Zora and Jill, for taking your time. Lastly, thank you so much, Abbott, for sponsoring this. Again, please feel free to reach out to Lakin and Adrian and anyone at PSPS if you'd like to get more information about anything that we've talked about. And again, if you aren't coming, I'm so sorry we'll miss you in Hawaii, but otherwise, look forward to seeing you in Hawaii and at our APP conference the day before. And again, please, 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 if you're not a member or you have friends that aren't members, please help them join. Thank you again, ladies. It was such an honor to be on this panel with you. I hope you both have a wonderful night. Thank you, everyone.
The same. Bye.